Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe to my channel and also please give the valuable comments. You can also visit the playlist. In the playlist, I have provided almost all the cases or topics in a very systematic order, and this is quite convenient for this. My dear friends, probably today we will going to discuss the last part of this rickets, and that is approach to the refractory rickets or approach to a case of vitamin D dependent rickets. Now, by the time you know now refractory rickets, what is meant by refractory rickets? We know that the child is not responding for vitamin D supplementation. Okay, still the problem continue. Then it is called as refractory rickets. Then we have to rule out the important causes like renal failure and renal tubular acidosis. Okay, for the refractory defects or dependent rickets, two important causes are from the renal failure and renal tubular acidosis. Now, for the renal failure, you just do the serum creatinine level, blood urea, and if these two are elevated, then it is indicative of renal cause. Suppose the creatinine and urea is normal, then go for the arterial blood gas analysis, and in arterial blood gas analysis, if you find acidosis, then it suggests renal tubular acidosis. Very simple. Okay, now renal tubular acidosis children will usually present with a short stature because it's a long-standing problem. So child will have growth failure, short stature, failure to thrive, and the typical ricketic features, especially with the distal area more. Okay, so that suggests you of renal tubular acidosis. Now come to another possibility where even ABG is also normal. Okay, blood urea creatinine is normal, ABG is also normal. Now what to do? Still child is having ricketic features. Now we have to consider calciphenic rickets, phosphopenic rickets, and pseudoparathyroidism. Now this is a new topic. Okay, calciphenic rickets, phosphopenic rickets, and pseudoparathyroidism. As in both the cases, the phosphorus is low. How to differentiate? The important investigation is PTH and calcium. Now, hypophosphatemic rickets, phosphorus is low. Calciphenic rickets, phosphorus is low because they are interdependent. Okay. Now, this being the case, how to differentiate? When the phosphorus is low, is it a calciphenic rickets or is it a phosphopenic rickets? The differentiation is quite difficult. Okay. So, how to differentiate it? The two important investigations, one is PTH estimation and another one is calcium. How to do that? See, these are the symptoms of calciphenic rickets and phosphopenic rickets. In calciphenic rickets, the patients are tend to be symptomatic and sick, and they present with the tetany, etc., Trojer signs, etc. So they present earlier to you. Calciphenic patients, so they will report to the doctor earlier because they will have a lot of problems like tetanic convulsions and all those things. Whereas phosphopenic rickets, where the phosphorus is the cause of the rickets, they are not as sick as that of the calcium deficiency, and they will be there without any much symptoms, and they will present to you at the later age. Even after 20 years, they present to you because nothing is done. Then only they will come to you. Again, in calciphenic rickets, they are classically with the upper limb involvement, tetany and all those, the upper limb involvement. Okay, whereas phosphopenic rickets, the patient will have lower limb involvement. They have the dental enamel hyperplasia, that is calciphenic. Whereas phosphopenic rickets, they are present with the dental abscesses. Okay, now calciphenic rickets, you will have high PTH. Whenever the calcium is low, parathyroid gland will be stimulated and it is secreted in excess to maintain the dynamic equilibrium of the calcium from the bone to the blood. So PTH will be increased. But in phosphopenic rickets, it is not like that. It will be normal because PTH itself is a phosphorus thrashing hormone, isn't it? So, so this will not happen in phosphopenic because already phosphorus is low. So why PTH will go into secrete? Okay. Now, low calcium in the blood will be there in the starting point in case of calciphenic rickets, but normal calcium concentration will be there in phosphopenic rickets. Phosphorus is very low, Obvious, when the calcium is low, phosphorus is also low in calcifenic rickets. Even phosphenic rickets, anyway, the phosphorus is anyway low. So why there is low phosphorus in both cases? Whenever there is low calcium, PTH is stimulated, parathyroid hormone is stimulated, then there will be calcium reabsorption happens and the phosphorus excretion will happen. So there is low phosphorus. Okay, so calcium reabsorption is also happening. So there will be near normal level of the calcium in calcifenic rickets. Initial trigger may be the low calcium, but once the PTH secretes, the calcium may be near normal. So ultimately, only differentiating factor is parathyroid hormone. If the PTH is increased, it is calcifenic. If the PTH is normal, then it is phosphofenic. Let us see how to approach the calcifenic rickets. Calcifenia, there will be low calcium initially. So is it a problem with the vitamin D or is it related to calcium? No. These questions will be always there, isn't it? Now, see, calcifenic rickets we are talking. Calcium is low. That calcium low may be because of vitamin D deficiency or it may be absolutely because of a calcium deficiency. For this, again, we have to go for 25 hydroxyl vitamin D level. This represents the body stores of the vitamin D. And if this 25 hydroxyl vitamin D is normal, then definitely it is a calcium deficiency leading to calcifenic rickets. Now, if it is low, it suggests that whatever vitamin D we are taking in the diet or vitamin through the sunlight is not get converted into the liver. So there may be lack of exposure to the sunlight, low diet of the vitamin D, or there may be problem in the liver. So there may be problem in the 25-dehydroxy enzyme. So if this particular 25-hydroxyl vitamin D is normal, then it is not a problem related to storage problem. But calcifenic rickets patient is calcifenic rickets, but he is having vitamin D 25-hydroxyl level low. Then it is because of the vitamin D is not properly formed, and this leads to improper absorption of the calcium also, and therefore there will be calcifenic rickets. Okay, so suppose this 25-hydroxyl level is normal, then all the above things are also normal. Okay. Now let us see how to approach the calcifenic rickets. Now we have to think about 125 hydroxyl vitamin D that is in the kidney. This will take place in the kidney with the help of the 1-alpha hydroxylase enzyme. Many times we have told, and this is also considered as the active form. If it is low, if this is low, then it suggests that there is a problem in the kidney, or there may be problem in 1-alpha hydroxylase enzyme that comes under the category of vitamin D resistant rickets type 1, isn't it? So if 125 hydroxyl vitamin D levels are normal or very high, then it suggests that the metabolism of the vitamin D till the active stage is normal. किडनी तक जो है विटामिन डी का till kidney level the vitamin D metabolism is normal. Only in the kidney this particular enzyme is absent, therefore it is blocked. But there is a resistance to their action at peripherally. This also we have discussed. Now suppose if active form is not there, then it is VDDR type 1, and active form is there but still there is rickets. That suggested in the peripheral levels this active form is not able to work or able to bind with the receptors which is required for the calcium absorption. So suppose this is normal and mildly elevated, then we suspect there may be some diet insufficiency, or patient had received the recent treatment in the form of supplementation of the vitamin D. Now another is there will be low phosphorus. Suppose if there is low phosphorus, then mostly there is some problem in the kidney again. Now if you see you have to see if something else along with the phosphorus is getting lost. If glucose, protein, etc., other signs are also lost along with the phosphorus, it suggests that it's a tubular defect and it may be a renal tubular acidosis. Suppose only phosphorus get lost, then we have to seriously suspecting the kidney problem, like phosphatase send out. Kidney may be culprit or it may be a hero. It becomes hero when if the kidney is reabsorbing the phosphorus well. How do you know? Do the tubular reabsorption of the phosphate and tubular maximum phosphate by GFR ratio. How much phosphate is reabsorbed by the tubules? And if it is reabsorbing normally, it suggests that kidney is functioning normally. Okay. Now, if the absorption is low, suppose if the absorption is low, either it may be because of the low intake or it may be due to the malabsorption. When there is less intake, like in premature babies, etc., or because breast milk, if the child is taking the breast milk, baby is taking the breast milk, without any supplements, or the children on elemental diet like new kids may have this deficiency. Kidney is losing the phosphates. Now, kidney is not a hero, kidney is now a culprit. That is, tubular reabsorption of the phosphate is very less. Then we have to do 125 vitamin D active form. Why? The renal causes of phosphatemic rickets are there. It can be a fibroblast mediated growth factor 23, phosphatids, what we are telling, mediated, or non-fibroblast mediated growth factor 23 mediated. Fibroblast mediated growth factor 23 will always going to inhibit 1-alpha hydroxylase also. This part also we have discussed. Any rickets which cause or mediates the FBGF23 will also block the 1-alpha hydroxylase, and formation of the active form of the vitamin D, that is 125 vitamin D, will be blocked. So if it is high, then it suggests that it is non-FBGF23 mediated hypophosphatemia rickets. Example is hereditary hypophosphatic rickets with the hypocalcemia, which is an autosomal recessive type of hypophosphatemia. Okay. Now we have to think about urinary calcium and urinary phosphorus. Urinary calcium is reduced in all the cases, okay, all the causes, except a diatic phosphorus deficiency and autosomal recessive type of hypophosphatemia rickets. Urinary phosphorus is increased in all the cases of rickets, all cases except the dietary phosphorus deficiency or in a chronic kidney disease, only condition where serum phosphorus level increase. So these are some of the pictures of dependent rickets, and this is a very important chart which shows the level of calcium, phosphorus, PTH, then 25 OH, 125 OH, alkaline phosphatase, urine calcium and urine phosphate. Okay, and these are the different causes of rickets mentioned here. Vitamin D deficiency, VDDR type 1, VDDR type 2, chronic renal failure, dietary phosphate deficiency, X-linked hypophosphatemia rickets, autosomal hypophosphatemia rickets, hereditary hypophosphatemic and hypercalciuria, autosomal recessive hypophosphatic rickets, dietary calcium deficiency, and Fanconi syndrome. All these conditions which lead to rickets have been listed here, and all the investigation findings are explained here. And one thing you can see, urine phosphate level is always increased in all the conditions. Another you can see alkaline phosphatase level is almost all increased in all the conditions. Okay, talking about 25 OH level, that is decreased only in vitamin D deficiency. In all the other conditions normally it is seen. Okay, storage form. Similarly, talking about urinary calcium level, okay, so in some condition it is increased, in some condition it is decreased. So you just go through this chart also to have a clear-cut idea about the rickets and investigatory finding. So with this we conclude the rickets. Thank you very much. From next class onwards, we'll start with another important topic, new topic. Thank you very much.